Welcome or welcome back to our series. I'm grateful you're here. I hope you're all safe and possibly even enjoying some time outside. Before we introduce today's session, you can find our updated programming and a new newsletter on the web. Just Google Greenberg Bladder Cancer Institute. Next month on the 13th, we will be welcoming Drs. Armin Smith and Ginny Hoffman-Sensis to talk more in depth about their teamwork in women's bladder cancer. And I wanted to draw your attention to a new group of programs specifically tailored around the experiences of women with bladder cancer, developed and led by Drs. Armin Smith, Ginny Hoffman-Sensis, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper-Greenberg. Their next program on December 6th will be led by Dr. Kim Pierce around those important moments when moving on to survivorship and in transitioning back to your primary care doctor. Again, all of these are up on our website. And if we can help you directly, we're only an email away at bladdercancer@jhmi.edu. I'm grateful to all of you today for joining us for a conversation with Dr. Max Kates and Mr. Brent Richmond. They are joining us today for a conversation about making decisions on procedures in bladder cancer. I appreciate Dr. Kates' approach to the session today. He intends it to really be a conversation with himself and a chance to hear from Mr. Richmond directly. Dr. Max Kates is a Brady-trained urologist who attended Mount Sinai Medical School in New York. Max is a leader here in the Greenberg Institute, where his practice focuses on patients with bladder cancer. He has received recognition nationally from numerous organizations, including the American Urological Association and the Bladder Cancer Advocacy Network. However, it is the feedback from his patients and families and his strong sense of communication which has inspired this conversation today. Brent Richmond is happily retired since 2016. He worked 40 years in the banking industry prior to that time. He enjoys spending time with his 5 grandchildren and traveling with his wife, Marianne. He is still an avid golfer. He's 69 years old and lives near Lancaster, Pennsylvania. Brent has been a cancer patient since October 2021. He did 3 months of chemotherapy last winter in advance of having radical cystectomy surgery performed by Dr. Kates in early April of this year. He is currently continuing treatment with monthly immunotherapy infusions. Dr. Kates and Mr. Richmond have agreed to have a discussion for about 30 minutes, and then we will have a larger conversation with all of you. Please feel free to put questions in the chat. Dr. Kates.
Hi, everyone. I always love and look forward to this session, and I'm thrilled to do it. And I like, one of the things that's so thrilling about it is I find that every patient's journey is different, and there are common themes, and I see a lot of patients and patient advocates I see on the attendee list, so I know you're listening in. There are common themes, but everybody's journey is a little different. But I think hearing about sort of someone's experience is so important. And before I have Mr. Richmond introduce himself, I'll just tell you that in the last 2 years, we've truly expanded our sort of patient-to-patient interactions, and that's been conscious. So subtle things like patients before surgery, major surgery, now have a list of other patients and their phone numbers who have volunteered to talk to patients, and those initiatives I think are part of a larger movement in medicine to make the doctor I give advice, but also a facilitator of what is the best thing for you. And having patient-to-patient interactions is so integral to sort of that movement. So, without further ado, Brent, do you just want to introduce yourself to the group however you want? And then basically, I have not prepared him for this, by the way. Basically, I'll take you through sort of, I'll ask you questions sort of about your own sort of cancer journey.
Sure, that's great. Well, as David said in the introduction, I live in Pennsylvania near Lancaster. Worked in the banking industry for 40 years, all in this area. I've got 3 kids who in turn have provided me with 5 grandkids, which is a wonderful thing. It's been a great distraction for me the last 12 months as I've dealt with a lot of the health circumstances that we'll be talking about today. Other than that, I'm still enjoying an active lifestyle. Certainly resumed traveling now that the pandemic has calmed down a little bit. We, as mentioned in the intro, I'm an avid golfer, so I like to do that every chance I get. My wife and I enjoy traveling. We've been a number of fun places even in the last year. So, I guess part of the message in all of this is that life can be very normal when dealing with cancer and bladder cancer in specific, and certainly there's no reason to stop trying to live a good life. So.
Okay, great. And by the way, while we're talking over the next period of time, if any of the attendees have sort of questions, just, fire them away, as they come, and then we'll address them sort of when we get to it. So let's get started I kind of want to understand, and I purposefully, consciously did not review your chart before this because I wanted this to feel sort of more organic. But let's kind of start with sort of before you started this sort of bladder cancer journey, did you have a lot of health issues? How would you have sort of conceived of yourself?
Well, I would say I've been a very healthy individual all my life, really. The only real hospitalization I've had as an adult was a knee replacement, which was about 7-8 years ago now. But the one thing that really I did deal with for a good 15 years in the run up to this cancer diagnosis was, functional issues with my bladder. That started for me in my early 50s. And a long story short there is that I was discovered to have a very large stone in my bladder, which developed over time in an outpouch that had developed in my bladder. So over a period of time, my bladder had become distended, which basically means it was enlarged, and the muscle walls in the bladder weren't able to function as they normally would. So I had difficulty excreting urine, from my bladder for quite a long time. And eventually that led to starting to self-catheterize in order to get my bladder completely empty to avoid recurrence of the stone that I had. And eventually, over a few more years' time, I really wound up having to catheterize all of the time in order to empty the bladder of urine. So, that was an interesting journey. Certainly not a very comfortable thing to consider in your early 50s, but quite frankly, in a very short period of time, that became second nature. The physical aspects
Were
of
you
that.
going into work when you were self-cathing and kind of cathing at work and doing the whole thing?
Yes. Yeah. I mean, that was really not a difficult task. You'd like a little privacy when you do that, as much for anybody else that might be there as yourself. And over time, there were a few instances annually of UTIs, urinary tract infections, which we dealt with a standard antibiotic script. But obviously, over probably the course of 15 years, I feel like all that irritation and probable inflammation likely had something to do with the development of this cancer in my bladder. I don't know that for sure, but that seems logical to me. So that was the big health issue for me, but it really became more of a lifestyle thing than anything else. I didn't feel like it was an impediment to anything I did, and it wasn't. But obviously the discovery of the cancer in the bladder, that was a different thing to reckon with.
So how did that come about?
Well, and this all started October a year ago, so just about 13 months ago. I began to have pain sensation in my very, very low groin area. And simultaneously also in, I can't even call it my back. I mean, really below my low back, I guess I would say, but, several inches below my waistline. And I just knew from athletics and other things I'd done in my life that this wasn't muscular and this was not like anything else I had experienced. So, immediately went to see my urologist because obviously I'd been treated by a urologist for many years with the urinary issues I had previously had, and also my family doctor. And of course, the immediate recommendation was let's get a CT scan done and see what's going on. So we did a CT scan, we did an MRI, which ultimately confirmed what the CT scan had to say, which, yes, indeed, there was a tumor in my, lower part of my bladder, back in the posterior part of the bladder. Following that, there was, we did a cystoscopy to
All right,
get a sample of the tissue.
let's pause for a second because I want to talk for the rest of the attendees. So the fact that you had a urologist already with what I would call an atypical presentation of bladder cancer is very fortunate, to be honest with you. The classic signs and symptoms of bladder cancer would be hematuria, so blood in the urine. And the second most common would be somebody who has a mass in their bladder identified on like a CT scan, a CAT scan, or an ultrasound. Your feelings of sort of pelvic pain and back pain are far more subtle, and in that way, far more difficult for a primary care doctor to know necessarily to refer to a urologist. So that's just something that interests me, hearing it now in this way, that you had a built-in relationship with the urologist, so that when you had these subtle findings, your urologist thought, well, maybe I'm going to just take a look in the bladder.
Yeah, one of the thing I would point out too, because you mentioned the hematuria as a presenting symptom, with my condition in my bladder over all those years, I had numerous instances of, blood in the urine, everything from subtle to gross hematuria. And candidly, it got to the point where it just didn't upset me. It was a normal thing that happens, 2-3 times a year. And, at that point you knew, hey, let's call the urologist or go see the urologist. Let's get a urine sample taken and see what's going on. So I did have probably 2 instances of hematuria in advance of this scan that I had done last October. One would have been in probably late July and the other in late August or early September. And it was unusual for me to have 2 such instances that close together. So, and I did consult, my urologist at that time, and, did the normal test, but we didn't do a scan at that point. We really didn't do that until the pain symptoms developed. And again, fortunately, as you said, I was already seeing someone, and, was maybe smart enough to know, gee, I don't want to mess around with this. I did, just because I know this isn't normal.
Right. So they did the cystoscopy. I presume they found a bladder tumor.
Correct. Which showed on the scan, and, biopsied the tumor. And obviously that's what led to the diagnosis of the muscle invasive bladder cancer. Right.
So first decision point you had to make is to seek out. Did you seek out a second opinion, or were you referred for a second opinion?
Given my history, I really wasn't concerned about that. I felt pretty confident that diagnosis was correct.
I more mean, how did you get to us?
Well, yes. My primary urologist certainly described without hesitation that the gold standard for treating this type of bladder cancer was removal of the bladder. Certainly a disquieting thing to hear. But within a day or two, that sort of settled in, and we got busy talking about where do we want to go for surgery, and did a little research locally, and just didn't see anybody locally who, in my mind, specialized every day, all day at that particular type of surgery. So we actually went to Sloan Kettering in New York first, which, where I live, I can get there in about 2.5 hours. And we're fortunate, at least I am here, to have, two great, such reputable, and highly regarded cancer treatment facilities as Johns Hopkins and Sloan Kettering. So we went to Sloan Kettering, met with the surgeon there. He certainly looked at all the history, described the surgery that you ultimately did. And I think it was the following week we had an appointment set up with you. And frankly, I found you through internet research. I mean, Hopkins has a very robust website, and certainly the Bladder Cancer Institute there is no exception. There's a wealth of information there, and frankly, it was not a difficult thing to find you and look at your resume and your history and whatnot. And somehow, miraculously, I got an appointment just by calling on my own. I wasn't referred, so I'm not quite sure how that happened. But so I came to see you, and your approach and the doc I saw at Sloan Kettering were very similar. And frankly, at the end of the day, the doctor at Sloan Kettering said to me, all things being equal, geography matters. You really need to be as close as you possibly can be to your treating facility in the instance that you have post-surgical complications, because in that event, most likely you'll need to get there quickly, which I thought was a great thing for him to say. He wasn't, he was basically telling me, hey, in fact, he knew you. And he said, yeah, Dr. Kates is great. That's a great facility. I would highly recommend that that's the choice you make. So that's how I got to you.
So thanks. I don't know if I even knew that. So that's interesting to hear. So let's get to the crux of some of the decision points now. So, newly diagnosed muscle invasive bladder cancer. So we got some imaging on you, and we were concerned that not only had your bladder tumor been in your bladder, but we were concerned that it was involving potentially your prostate as well, and that it was growing into your prostate. And you were a guy who was already self-catheterizing. And all of these data, all of these things are important because our discussions first centered around, is this a bladder worth keeping? Is there a way to keep this bladder? Meaning, could we do chemotherapy and radiation, which is called trimodality therapy, and preserve this bladder? And if we do preserve it, what kind of quality of life would you have? And or is this a bladder that should be removed, with the prostate? And if we do that, what urinary diversion would you want? Would you want a neobladder or an ileal conduit? So these are two separate decision points. There's a decision point of to have your bladder removed, and then there's a decision point of a urinary diversion. And I'm curious how sort of that process was for you in making the decision. Was it difficult? What kinds of things did you weigh? And how did you sort of come to the decision that you came to?
Sure. Well, let's tackle the first part of that first, and that was the decision to have the bladder surgery and remove the bladder. All of the medical people I consulted, which were my local urologist, the surgeon at Sloan Kettering, and as well as you and your team, we're pretty clear about, that's the best way to treat this particular form of bladder cancer. This is not the usual form of bladder cancer. It's not self-contained, not easily treatable. I also had, the makeup of my particular tumor was heavily oriented towards squamous cell, which was another decision factor in opting to have the removal done. And I'll be honest with you, at the end of the day, it was my youngest daughter saying to me, "Gee, Dad, that bladder hasn't done you any good for the last 15 years. So let's just get rid of that thing."
I actually want to stop you there because I think that's something that's lost in a lot of conversations I have with patients where we talk about preserving a bladder and I just want, sometimes I'll just say time out. What is your current quality of life with the bladder that you have? And how do you experience that quality of life? And sometimes there's a pause and patients, and sometimes it's a couple days later where they're like, yeah, actually, this is not a bladder that's done me any good. So I think that is a very common actually scenario. It's not by any chance all of patients, but it is some patients.
Sure. And again, for me, it just all those factors sort of fell into place. My history, the medical advice I got, the family support and advice I received there. So again, at the end of the day, it was not a difficult decision. Now, as far as the diversion goes, and again, from the time that this was diagnosed until, and I don't recall when you and I first met, it was probably in December or January, I would think. You spend a lot of time doing a lot of research. Fortunately, today, there's lots of great sources for that research available through the internet, obviously your website. Sloan Kettering was another place I spent a lot of time. Some of the national organizations that are out there dealing with this specific type of cancer, spent a lot of time there. And that was the primary research that I was doing at that point in time was, gee, what's the best lifestyle solution for me going forward? And candidly, it just seemed to me that the pouch and the ileal conduit was certainly the most prevalent diversion that was being done. It's been being done for a long, long time. There's one or two folks that we know, friends and family of friends who've had this same surgery who have been dealing with it for 12, 15 years. Which I thought was a positive point. And frankly, the neobladder and the Indiana pouch system, which again would involve continuing catheterization, I was ready to be done with that, quite frankly. Just sort of it seemed like an easier lifestyle choice for me to do what I did. I wasn't really a fan of having to deal with incontinence and some other things that seemed to come along with those other solutions. And I still felt like, absent this particular issue, I have really good health. No particular reason to think I'm not going to live a lot of years and be active in those years. So also looking for something that I could be comfortable with in resuming a normal life.
Yeah, that was a great response, sort of how you thought through that. There was another sort of decision to make before we actually get to the surgery and sort of the aftermath, which is, chemotherapy. Can you tell me about, undergoing chemotherapy before surgery and what that process and experience was like for you?
Certainly. Well, I did 3 months of chemotherapy, essentially the months of December, January, and February. Fortunately, we have what I consider to be a very good cancer center here in Lancaster, at Lancaster General Hospital, which is part of the Penn Medical System. Got referred to an oncologist there that we immediately, bonded with. A very open guy, easy to talk to, and very honest with me, I should say, about options when it came to the chemotherapy. And we discussed, 2 treatment options. One which I ultimately did, which was the gemcitabine cisplatin approach, where my treatments were every 3 weeks was the cycle, and day 1 was a long treatment, a 5 or 6 or 7 hour treatment, and then day 8 was a shorter treatment of closer to 2 hours, and that was the less intense choice. And a lot of that was predicated on, my current situation at that time. And there was no reason to believe that that wasn't going to be effective in helping to reduce this tumor, which at the end of the day it was. I was, and I say this to people all of the time, I was and I continue to be very, very fortunate through all of this process. I'm one of the lucky few who really didn't have any particular adverse effects to the chemotherapy. The last probably 2 treatments, I had some fatigue, into the second day, but it was by no means debilitating. And other than that, I went about my business normally, and was a little more careful with diet and caffeine and alcohol, things like that. But physically, things went very well for me. I opted to have a port installed in my chest, which I still have, which I think was a wise choice. Just helps with, maintaining the integrity of the veins in the arms, which get enough of a workout with all blood work that I have done and continue to do. So, again, it was a family decision, I think, at the end of the day, in terms of, which avenue we were going to pursue, a more intense chemotherapy or something that was maybe going to be a little bit easier for me to contend with. And again, so far, seems like it was the right choice.
Can I interrupt and just ask a question I'm curious about that always, I don't really ask in clinic, but always, is different from patient to patient, which is, you, like many of my patients, have adult children. What did you share with your children, and at what stage? And is that something you talked to your wife about? Is that something that was conscious? How did you think through that?
Sure, that's a great question. So I've got 3 kids, all in there, from mid-30s to, I guess, my oldest is 40 years old at this point. And, like most people's children, they're all different. We actually approached each one of them a little bit differently with the news and how in depth we went with that information. And I won't get into the details of, which kid and what direction we went with each one, but certainly that was an extensive part of the conversation I had with my wife, before we really began to publicly, or even within the family, talk about the situation. So I would just say in one case, it was a full disclosure situation. One case, it was a minimal disclosure situation. And there was, of course, one that was sort of in between. So we sort of tailored the information to each of our kids and what we thought they would be best at handling. And again, I think that turned out to be a good decision. And I'll add one more thing that I think is really, really important. And it may be the single most important thing that I did throughout my diagnosis and chemotherapy and even to this day. And that's, I've never hesitated to talk to anybody about this condition and my cancer. And what I found in doing that, particularly early on, particularly in the first 4 weeks after diagnosis, was it helped me come to grips with, hey, this is a real thing. And not only do I want to get on with the treatment, but I want to get on with mentally understanding what it's about, what I have to go through, and, not being that person that says, oh, woe is me, why me? And I just found by talking to people, family, friends, making what I would call full disclosure. Hey, here's everything I know right now. Here's what I've been told. Here's what I think lies ahead. Here's the next steps. I found in very short order for me, that really helped give me mental peace of mind.
Yeah, that's great. As somebody with 3 kids myself, I can relate to each kid being very different. So that's not something I usually typically will talk about in clinic, and it's very interesting to know about. Okay, let's kind of move ahead. tell me about sort of, was there anything you did to sort of mentally or physically prepare for surgery? And then how was sort of the experience of surgery and this in its immediate aftermath?
Sure. So I had, like I said, I finished chemo the very end of February. My surgery was April the 6th. So I had about 5 weeks. And my first post-surgery scan wasn't scheduled till about March 10th. Or I'm sorry, post-chemo scan, excuse me. So in that time between completing chemo and start and getting ready for surgery, focused on some physical things, getting to the gym 3-4 times a week, walking as much as I could, weather permitting, diet, and actually trying to put on a few pounds, maybe 5 pounds or so. I weighed about 210, I would say, throughout all the chemo, and I think I was somewhere close to 215 when you did the surgery. And I've lost 20 pounds and kept it off. Thank you very much. Hard way to do it. But the the other thing really was more research, I guess, and making sure I was comfortable with the decisions that we had made about which diversion technique to employ. You were very good about describing the in-hospital experience and the surgical experience, which all proved to be true. The only issue, which you may recall, I don't know if you do, that came up for me was, I think the surgery was on I want to say it was a Monday or Tuesday it was scheduled. The Friday before the surgery, I began to have a recurrence of those presenting symptoms in my pelvis and low back. So much so, well, and I was scheduled to come to Hopkins for a COVID test and an ostomy nurse education program, I think on a Monday. So I came, and at that point, my BP, blood pressure was extremely low. I was lethargic. Pain was increasing. So I actually got admitted to the hospital 2 days ahead of time, which was a fortunate occurrence because, we did a quick scan when I was in the hospital at Hopkins and found that for whatever reasons, my tumor had regrown back to its original size. And it was, on March 10th, when I had my first post-chemo scan done, it looks like it had shrunk to about 50% of its original size. So within that roughly 3-week period, this thing had regrown rapidly. And, so that was really the only, hiccup I'd say along the way. But again, a short-term problem, certainly.
Yeah. How did you, so it's 2 days before your surgery, and now, we're telling you that your tumor is sort of regrown and probably was obstructing your kidney, which is why you were experiencing those symptoms. That's kind of tough news right before surgery to stay positive. So how did you deal with that?
Well, again, it just, for me, it sort of hastened the desire to have the surgery. It was, gee, let's get this done. The pain wasn't completely overbearing, but it was really uncomfortable. And it was more the notion that, gee, because this is already muscle invasive, how far has this escaped? Where's it likely to invade next? So for me, it was more about sooner than later. Let's get this done as quick as we can. There really wasn't any concern in the interim couple of days other than, gee, where's this going and how bad can it be, or how can it get before we get to the surgical table?
So, okay. So we do the surgery. I don't, once again, I did not look at your chart. How many days were you in the hospital?
Well, counting the 2 days prior to surgery, 6 days overall. So really the day of surgery and then 3 more. So, not too bad, all things considered.
Yeah, that would be actually, because there's a lot of patients on this attendee list, so I need to set expectations. That would be considered a rapid pathway. So
Right.
that's about the earliest that somebody is discharged. You were, that means, fortunate not to have any complications. Complications are very common after this. I always tell patients 30% of the time, patients will stay 6 to 12 days for some type of complication. But nevertheless, you had a rapid pathway. I'll explain. Now, you did not have the, obviously it would be cool if this was possible, but you were not in the operating room doing the surgery or seeing it. So I'll just explain that when we did the surgery, it was obvious to me actually that your tumor was obstructing your kidney, causing your back pain, and was also invading your prostate. We were able to get all of the cancer out, and thankfully none of it were involving the lymph nodes. But the tumor was, it was several centimeters in size. And so when we, before we get to talking about the pathology, which I want to talk about because at that point we had some decisions to make. Can you just talk about the 2 to 3 weeks immediately after surgery and what that was like?
Yeah, there's a couple aspects to that. Certainly there's the physical aspects of that, which in my mind sort of involve diet as well. I mean, sort of being careful with diet and, the one thing I do recall about the days in the hospital that all of the staff there emphasized more than anything is, gee, we really want to get your bowels moving. And so I was fortunate to not have any particular issues in the hospital there. Maybe that had something to do with me getting out sooner than later. But I was very cognizant of that in the weeks following surgeries, making sure I maintained a diet that made it easy for my bowels to be active, and be able to, have bowel movements with on a regular and in an easy manner. Also, walking, which again, the staff at Hopkins, emphasizes greatly while you were in the hospital. And I tried and I think succeeded at doing as much walking as I possibly could while I was still in the hospital. And then once I got home, slowly building up daily, and there was still some winter weather hanging around. So the days I couldn't get out and walk in the neighborhood, I'd walk in the house. And I can't tell you how many times I did laps around the first floor of my house, to try to get a mile in or mile and a half in. And slowly over the 3 to 4 weeks after surgery, I built up to doing, maybe as much as 3 or 4 miles of walking, all of which, and again, in the beginning, that was not easy. I mean, walking across the street to the mailbox was a task. Breathing was difficult and labored. There was, pretty lethargic, I would say, just overall physically. A lot of time not on your feet. So there's everything that was described to me that would happen post-surgery came to be.
Did I do your surgery through an open incision?
Yes.
Okay. Yeah, probably because it was invading the prostate, and I wanted to make sure we had clean margins.
Well, and the other aspect of the actual surgery itself, which you may or may not recall, was there was a real concern that the tumor was very close to it and perhaps invading my rectum.
Right.
Yeah. And probably the most uncomfortable piece of information I got from anybody in the whole process came from you the morning of surgery, when you explained that to me 15 minutes before I got put to sleep. Right. And that, oh, gee, you might come out of this with a colostomy as well. Right. And I went white as a sheet.
Yeah. I'm so happy we didn't have to do that.
Yeah, fortunately that didn't happen. But but that was obviously a concern you had, and it didn't come to pass. But the other big issue post-surgery, which I'm sure we'll spend some time talking about, and I expect that there'll be some questions about, is what I call the lifestyle aspect.
Yeah, that's what I wanted to talk about next. Sort of, how is your life different now?
Well, and it's certainly much better now than it was in the weeks following surgery. Getting used to, the pouch, the bag, whatever you want to call it, was a frustrating process. It took some time. And frankly, that was really, after a while, it became clear to me it was really a function of finding the right, equipment, for lack of a better term. There's a lot of manufacturers that make a lot of pouch products. I can't tell you how many I tried. It was a lot, until I finally got to the right solution for me, which I would say I've had now for about 3 months. So, at this point, I'm able to go 3, 4 days wearing a pouch. I empty as frequently as I think I need to, but I'm very conscious of emptying the pouch whenever it's convenient to do so. It certainly doesn't seem to hold as much urine as my bladder did. Of course, my bladder was distended, so that may have had something to do with that. So I take every opportunity to empty whenever I can. The changing of the bag has gotten to the point where I'm very self-sufficient doing that. And believe me, that took a while. The home health nurses were very helpful. Rhonda, obviously, your ostomy nurse there, who's terrific, was very helpful. My wife, obviously, very hands-on, very helpful. But it's people should expect frustration. It's a frustrating thing to have to deal with. So much so that the day I was discharged, we weren't 10 minutes down the road, and my bag leaked. So, I actually called the hospital, got the nurse that escorted me out, turned around, came back, we did another change, and, home I went. So, dealt with a lot of leakage over the first probably 2 months. And again, I really came to realize that was just it wasn't me. It was just a function of finding the right product to use, based on my shape and the stoma itself, et cetera. So, I would just encourage everybody to be patient with that. And everything you read is true. You will find a solution that works for you. And when you find that solution, you'll become comfortable, eager to go out and about and do the things that you normally did.
You playing golf? What's golf like? When did you start playing golf again?
I fooled around in July, go out and hit a few golf balls here and there, nothing serious. But I started in earnest in August, so 3 months.
Yeah.
And again, it was, you find yourself being very careful in a lot of things, taking a shower, even, sitting, bending, standing. But again, after a while, you become accustomed to the fact that this thing's there. You become comfortable that I've got the right appliance on. It's not going to leak. It's not going to give me a problem. And when I travel, obviously I carry extra supplies to be safe. But I've had no problem playing golf, no problem walking. I haven't been on an airplane yet, but that's coming up in a couple of months. Done, a week away from home, that sort of thing. All very manageable, all good.
So I want to get to some questions, but before I do, the last decision point you needed to make is whether to go on immunotherapy after surgery. Do you want to talk a little bit about either our conversation or the conversation with the medical oncologist and sort of how you came to decide to do that? Because first of all, I want to give a background to the audience. So a year ago, a new FDA approved therapy called nivolumab was approved for patients with persistent muscle invasive bladder cancer after chemotherapy, exactly like Brent had, to essentially try to avoid a recurrence. Before that, we would typically get CT scans every 3 months, hoping that the cancer would not come back. And a lot of times it did not, but sometimes it did. And so this therapy called nivolumab is given, how often are you taking it? Monthly?
Well, it started out biweekly. The first 3 months, the treatments were every 2 weeks. And then based on how I handled it or what reactions or side effects I did or didn't have, it has now gone back to a monthly regimen, which I will continue to do until I guess it's May of next year. So it's a one year treatment program all in.
Right. So this is incredibly new, within the last year. So do you want to talk a little bit about how you decided to do that?
Sure. The medical advice really was that, this particular treatment seemed to, in many cases, enhance the opportunity for a cancer-free outcome by, as much as 10 to 15%, versus not doing the immunotherapy at all. And again, in my case, because I was so fortunate with chemotherapy and had very little adverse reaction to it, the decision to do the immunotherapy seemed pretty easy. Now, I will say that the side effects that were described to me are a little bit more daunting and potentially much more severe than the chemo. I don't remember all of the specifics, but there can be adverse involvement with the heart, to some extent the lungs, and those are watch factors in doing immunotherapy. And the blood work I do blood work the day before each treatment and the day after each treatment, to keep an eye on kidney and blood, obviously, condition. So for me, again, it just seemed like it fit the course of treatment that I had already gone through. And I'm a numbers guy, so I like things that increase my odds. and it did seem like, to the extent that any of these more difficult adverse conditions or would develop in my case, they stop the therapy, they administer, I think, some steroids to try to reverse whatever the adverse effects of the therapy are, and down the road you go, hopefully no worse, for having tried it. So, it just seemed to me like the right best thing to do at the time.
Yeah. All right, let's try to answer some of these questions with the time we have left. Some I think are best for me to answer, some are best for you to answer. So we'll just go right down through them as they came in. So is there data to support one regimen over the other with squamous cells? So I think this question is referring to whether, David McConkey, our fearless leader, just happened to show his face during this question, which I may throw off to him. So pure squamous cell carcinoma, we do not typically give neoadjuvant chemotherapy for. That is not what Brent had. But there is an entity called squamous cell differentiation, which is typically associated with a subtype of bladder cancer called basal subtype. And there's some really innovative research that's been done to try to figure out whether one chemotherapy regimen before surgery is more or not effective for that. So you're asking a very hot question. David, do you want to address that? Because I know this is something that probably as much as anybody in the world on. You're muted.
Thanks, Max. Yeah, so we do think chemotherapy works in tumors with basal squamous differentiation. We also think that immunotherapy works in those tumors. And actually, in the Southwest Oncology Group, we're designing a clinical trial. This is a trial that's really led by Josh Meeks, a colleague of mine at Northwestern, to assign patients with squamous differentiation basal tumors to receive a novel immunotherapy combination or chemotherapy. They'll be randomized to one or the other. So yes, if you have basal squamous differentiation in your tumor, we do think you'll benefit from chemotherapy. With pure squamous tumors, I think most medical oncologists would suggest that there's not much benefit.
Yeah, so great response. So Brent, we think that your regimen is nicely adjusted for your type of cancer, but every patient's tumor is slightly different from the next. Okay, so this is a question about post chemo. What, if any, are the lingering side effects? So full disclosure, I'm just a simple country urologist. I am not a medical oncologist. But what I can tell you and what I teach my residents and fellows is before somebody undergoes chemotherapy for bladder cancer, before surgery, neoadjuvant chemotherapy, this is a drug called cisplatin, or platinum is the class of drugs. And these are famous for affecting three things. And this is the three things I usually screen for even before I'll send the patient to a medical oncologist. And that's kidneys, kidneys, hearing, and neuropathy. So peripheral neuropathy. So I'll typically ask patients about their kidney function, or I'll look it up. I'll ask patients about their hearing, and I'll ask patients about their sensation, peripheral sensation, if they have peripheral neuropathy. Those are typically the three main reasons why we would not recommend chemotherapy before surgery. There are some others, but those are the three sort of big ones. And those are some of the side effects. Brent, did you have any of those side effects from chemotherapy?
Not really, no. I mean, certainly no neuropathy. As far as I know, my kidney function has been pretty good throughout. And other than my wife's take on my hearing, which I'm sure she would say is not as good as it needs to be, as far as I know, I haven't really had any hearing issues before or after chemo.
Okay, I get the same complaints, and I have not had chemo, so all right, we have a question. Is there any evidence-based support for specific nutritional approaches? This is a fantastic question. In primary or secondary prevention of bladder cancer. So, nutritional approaches to prevent bladder cancer. This question I get every day, and the answer is we don't have great data yet. Okay, hopefully, one of our this is a little bit of a tangent, but one of our most recent hires, who's a urologist who's specializing in bladder cancer, essentially my partner. His name is Sunil Patel, and he is going to be focusing his academic work when he's not doing surgery on looking at environmental toxin exposure and whether it increase, and what environmental toxins increase one's risk of bladder cancer, and perhaps how we can then prevent bladder cancer from occurring by limiting toxin exposure. But this is an emerging field, and time will tell whether there's anything specific. David, would you like to add anything to that?
No, you summarized it really well. I think a lot of us wonder whether having a healthy diet will improve your chances of preventing recurrence or progression, but there just aren't very strong data around that yet. And I would also like to advertise Sunil's work, because he's a rock star, and he's really got some great ideas and collaborations in place already to help us understand some of these things.
Okay, let's now turn the question over to Brent, which is, how did you learn how to change your bag yourself?
Very, very slowly, and with lots of assistance. In the beginning, I would say I was mostly an observer and not a passive, and passive participant at best. And with each opportunity to change the bag comes, you need to have a willingness to get a little more hands-on, regardless of what that looks like for you. One of the big decisions I think to make is, where are you most comfortable doing this? Would you rather stand? Would you rather lay down? Something be in a chair. I don't think there's any particular guidance on what's best. That's a personal choice. So I think, you want to, along the path of discovery, you want to try to figure out for yourself, where are you most comfortable? Because I think that gives you the best chance to, take on more responsibility for changing the bags on your own. And in the beginning, it felt like it took an hour, with lots of different hands coming at me, helping me, prepare the area, trying to keep the skin healthy, and at this point, it's 10 minutes maximum, maybe. And again, all I can suggest is that everything you read is true. It will take some time. And again, the biggest part of it is finding the right equipment / appliance to apply. based on your stomach shape and size, and basically how your abdomen looks and what size and shape that is. So I just tell people be patient, because it's going to take some time, and you're gonna have some uncomfortable moments and a lot of frustration. So there's really no magic to it. It's just a process where a little more time and a little experimentation, and ultimately understanding that the bag itself is not as fragile as you might think it is. I've never had an instance where the bag itself was punctured or leaked because the valve came loose. It comes down to how the flange or the appliance itself adheres to the skin. And there's a whole process to doing that. And again, you have to find what works for you, because there's lots of accessories you can use to make that easier, or more beneficial, depending on your personal circumstances. And I tried a lot of those. So it's trial and error, it's patience, willingness to be active in your own care.
Yeah, and I'll just say anecdotally, I've met very few patients 6 to 9 months out who are still having issues. If there are issues, usually it's initial, and it's just working things out. All right, so I'll take the. All right, let's see. Do you change your bag by looking in the mirror? That's a good question.
Well, not very often. I'm a guy. I've done most of it, sort of lying on my back or propped up in bed.
Yeah.
I've done it a few times standing at the mirror. And frankly, that's something I need to get better at. And what I have found is, I need to have a situation occur that makes me do that. I need to have that happen on an airplane or somewhere where I have no choice but to change it standing up, looking in a mirror. And frankly, that's a lot of how I got to where I am today, is just by dealing with circumstances as they come up.
All right, I'm going to take the last question, which is, remind me, have you spoken to other patients since your surgery?
Yes, several, in fact, friends of friends, as well as some people that have been referred through the Johns Hopkins Network.
Okay, so what do you find as what are people? First of all, why have you decided to sort of share your story either in this forum or with patients that call you, and why have you volunteered in that way? And then what do you find to be the thing that people are most anxious about as a general theme, and how do you respond to that? And then I think we'll wrap it up.
Sure. Well, I'll take the second question first. I think the prevalent thing that people have wanted to talk to me about is the lifestyle change. A little bit about the chemo, certainly focus on the surgery a little bit. How long were you in? Any complications? What did that look like? But it's mostly the post-surgical lifestyle change. Everything from dealing with the bag to, how do you get comfortable? How do you get comfortable? Meeting with people. How do you get comfortable going out to dinner? How do you get comfortable driving in the car? Those kinds of things. And I'm sorry, what was the first part of the question?
Why have you decided, this is a perfect wrap-up question, why have you decided to volunteer why do you give your phone number out in the surgery packet, and why have you volunteered today? Like what,
Well, part of that goes back to what I said earlier about what has helped me personally deal with my condition mentally. And that's early on, for whatever reason, I decided this is, there's no reason to be private about this for me. No reason not to share details when somebody asks a detailed question. And again, I found my discovery through all that was, gee, that has helped me personally deal with, avoiding any really negative mental outlook or aspects of either the chemo, the surgery, the post-surgery, all of it. And so for me, if I can help people get to that point, and if I can be relaxed and conversational and show them that there's a good reason to do that, and a reason that not only helps others, but helps them, then I'm only too happy to do it, to be involved.
And we're so happy you did. Thank you.
Yep.
This was wonderful.
Yep, you're welcome. Happy to do it.
And thanks to both of you for having this conversation. Megan, hopefully you saw my answers to your question in the chat. Last call. Do you have any final words, gentlemen, for the audience? Well, it's great to see everyone. Stay tuned. Remember, we'll have another one next month. You know where to find the information if you need to find the details. Thank you once again, and have a great month until we see you again.